with the risk of malignancy being 70 to 85%. Then we'll also look for, we'll go ahead with total thyroidectomy here.
Okay, why not hemi?
More than 4 centimeters, the risk of recurrence is more.
Why is it in papillary? Why is it so?
The micro, multicentricity is more in papillary.
Multicentricity. Okay. Then what else you want to do? 4 centimeters. Or three instances I'll give. Okay, 3 scenarios. So one is 4 centimeters. One is 2.5 centimeters. Okay, one side enlarged. Okay, and one is 1 centimeter we discussed, so I'm not discussing about it. The other one is with nodal palpable on the ipsilateral side. Take left.
Okay. More than 4 centimeter comes in T3. Now it is by size T3, no extrathyroidal extension, N0 status. We will plan for total thyroidectomy with central neck node clearance. In 2.5, we'll see again if there is extrathyroidal extension or not. And if it is N0 status, we can still do only total thyroidectomy. In an N plus lateral neck nodes, if it is central N plus, then only central node clearance. If it is lateral, we will do central with lateral.
Okay.
The side of involvement.
In other words, when will you do in a papillary CA? When will you do central? When will you do lateral? When will you do both?
In N0, that is central N0 neck for T3, T4, we will prefer to do prophylactic central node clearance. In lateral, it is only therapeutic in N plus.
So I think it is, madam, central is when there is lateral necks are positive, then we will do central. And if in central is suspicious,
what is incidence of central neck positivity? What is incidence of lateral neck positivity with central? Okay, what is incidence of like central compartment? When will you do central? For all cases of papillary CA, you will do central compartment?
T3, T4. Prophylactically, we'll do in N0. N plus you will have to do. In N0, T3, T4.
Okay. So you'll also see the other high risk features. Suppose they are more than 45, more than 45, more than 4 centimeters with gross extrathyroidal extension. Okay. Any aggressive variant of papillary. What are aggressive variant of papillary? Can you tell me variants of papillary CA before that?
Aggressive variants are tall, columnar, hobnail, sclerosing type, morular.
Madam, these aggressive do diagnose on FNEC, madam?
Aggressive no. Yeah, if it is, they give, if it is suspicious of PTC, they will give suspicious.
I'm talking this hobnail, these other types. Do we diagnose on FNEC, madam?
Yeah, they can see, no? That's what you see in FNAC smear. We discussed, no?
These varieties.
Yeah, they can see very well about hobnail, tall columnar. Okay. All this, they'll comment. Okay. Yeah, you tell me.
This neck node, should we first do FNAC or we have to take them radiologically, madam, to consideration?
You have to. If it is palpable, then you need to do scanning. Okay. So if it is peripheral, better picked up by ultrasound. Okay. If it is central compartment, it is better picked up by CT. So I asked you what is the incidence of central compartment with presence of central compartment. How much lateral compartment can be positive?
Less than 3% if N is positive in central. Vice versa, lateral positive, 80% of central will be positive.
Yes. So almost always in all cases of lateral compartment positive, you have to do central compartment. Okay, it's not other way around. Okay. So, and when there is multifocality with gross thyroidal extension, any nodal metastasis is present on pre-op evaluation or any evidence of distant metastasis, in all these cases, 8 से लेके पूरा ये features जो है वो सब high risk है. Okay. In that, you have to address the
central
lymph nodes. Okay. Yeah.
prophylactic.
And in other things less than 45, less than 1 centimeter, differentiated thyroid cancers with unifocality, with no nodes, okay, no distant metastasis on evaluation. Still, you can observe nodes, okay, and especially in very young age, less than 15 years of age, you have to address, okay, they're aggressive, okay. Then, yeah, what did
variants of PTC? Classical and aggressive.
Why are we tell me variants of PTC, variants of FTC.
Classical type, aggressive or tall columnar hobnail sclerosing morular type. Then
morular is in papillary, na? I don't
papillary.
know morular is in.
These are all papillary only, no? Classical and aggressive variants are papillary.
What are follicular?
Follicular. Hurthle cell type is now a separate entity. It won't come in follicular. The others, papillary type.
Minimal invasion.
Vascular invasion.
Widely invasive.
Minimal invasive vascular invasion.
Extensive angioinvasive, minimally invasive, widely invasive.
Okay. So, yeah. Then we discussed about anaplastic. Medullary.
Types, ma'am.
We discussed medullary features, no? FNAC. That's it. Sorry.
VB.
Okay. Yeah. So, okay. Now, in papillary, you told this is the addressing of the lymph nodes. What about in follicular?
In follicular, the risk of metastasis in NG, otherwise also it is less than 8%. So we don't prophylactically address until unless they are grossly involved or you can see them on scans and intraop.
Yes. Then what about medullary?
In medullary, you'll have to do prophylactic central with, if it is involved, then prophylactic lateral, same side as indicated, one step higher.
Anything related to calcitonin level?
More than 400. You'll have
No. It is related to each 50.
Less than 20 we can omit. Less than 20 we can omit.
20, 50, 200, 500. Less than 20 don't need to do lymphnopathy. Lateral. 200 is contralateral, lateral lymph node also. 500 mostly upper mediastinal nodes are involved.
So that is variation with calcitonin. Okay, more so in medullary thyroid cancers which are familial. Okay, how many are sporadic? How many are familial, Sana?
80% sporadic.
More than 80 to 90.
80 are sporadic, 20% are familial. So in medullary thyroid cancers which are familial, what do you want to do?
Medullary, ma'am, come again?
In medullary thyroid cancers which are familial.
Okay.
What is your line of management?
Since
there also we'll see for calcitonin
men one we have to rule out, since purely familial there are only 2 families, so men one we have to rule out.
So something is related to less than 1 year, less than 5 years, men to A, men to B.
Prophylactic surgeries. This proven you're asking or prophylactic?
Proven what is, you'll do anywhere hemithyroidectomy is there, medullary?
No, ma'am.
No. Yeah, it is always total thyroidectomy. What happens to lymph nodes addressing? It depends
less than 1 centimeter medullary, any role of hemithyroid? Less than 1 centimeter.
If there is no familial inheritance, yes. But very close follow-up is required. Okay. So, what about addressing the central compartment and lateral compartment? In a normal medullary thyroid cancer, suppose it is 4 centimeters, sporadic cancer, okay? What is your line of management?
Then one will get the calcitonin level. Depending on the prophylactic central, we will address. If the nodes are positive, then lateral is also addressed. If it is more...
Yes, it depends on the calcitonin whether to address it unilaterally or bilaterally or radiological findings. Okay. Yes. So, yeah. So, what about anaplastic? Generally, they don't come for operative this one. Whatever the surgeries we do in anaplastic are to relieve the decompressive symptoms. But if anaplastic are localized, and operable, do treat them aggressively. Okay, you have to address the lymph nodes also. Okay. This is about different this one and they're addressing through central compartment and lateral compartment. Why are we so much bothered about central compartment, lateral compartment? Why we should not do it aggressively in all cases?
The morbidity associated, it's a closed compartment where injury to RLN and surgical morbidity is more. So when
not only RLN, something else.
Majority they are like micromets and they do not affect the overall survival, ma'am. Through the recurrence rate is higher, but overall survival is same, ma'am.
Okay, but no, I'm asking why are you so...
Yeah, parathyroid.
Yeah, which parathyroid is more likely to be injured?
Inferior, ma'am.
Why?
Because it comes
location anterior to the compartment.
It's not constant in its location.
It's inconsistent in location.
Yeah. So, and for all practical purposes, you have to save superior parathyroid. Okay. So, yeah. Now, do you know any criteria for papillary thyroid CA? Okay. If it is smaller than, if you have seen a nodule, okay, and a lymph node, okay. So, any criteria were given for PTCs? The name of the criteria? Yeah, appearance illa. So, there were the criteria for management of micropapillary thyroid. Okay. So, for close follow-up, which you keep, no?
Miyachi. No, I only know the evidence.
Something from Japan?
Miyauchi is that paper I know, but
this Japan and MD Anderson, they gave those restricted area how to manage.
Yeah. So it was from Kobe University in Japan. Okay. So
and with
which
MD
they have given. Sorry?
With collaboration with MD Anderson, they divide into 3 categories. One.
Yeah.
Inappropriate, appropriate, and which cannot be.
Yeah, if there is any increase in size of nodule more than 3 mm and with inter-observer variation and appearance of new lymph nodes, then you have to address that. Okay. So, what is the incidence of, tell me the staging classification of thyroid? Differentiated and de-differentiated. T, N. Hello?
By TNM, 8th AGCC you're asking, huh?
Yeah.
Okay, less than 2 centimeter T1, T2, 2 to 4 centimeter T2. T3 is more than 4 centimeter with minimal strack muscle involvement, not minimal. T4 is again A and B. B is inoperable, prevertebral carotid. Rest everything like RLN, everything will come in.
So, in differentiated thyroid cancers, I'm asking about the stage grouping.
less than 55 and more than 55 age cutoff. There are two stages less than 55, 1 and 2. Non-metastatic is 1 and metastatic is 2. And in more than...
it's a node positive where it comes?
In less than 55, it is
Stage
1. 1.
Yes. Yes. So why it was 55-45 changed, Sahana?
The Nixon et al. Study said that in that there was no difference in overall survival.
They did not see much differences in that age group, so they have changed it to 55. Okay, so yeah. Then what about undifferentiated thyroid CS?
Anaplastic, they are stage 4 ABC depending on local, loco-regional or metastatic.
Okay. Okay, N staging.
N is N0, N1. N0 has A and B. If radiologically absent, biopsy also negative, it is A. Only radiologically present but not FNAC confirmed is N0B. N1, A is central compartment, B is lateral compartment.
N0A is like radiologically present and FNAC negative. N0B is not radiologically, not clinically, any node is there.
And N1 is?
Central N1A, lateral N1B.
Okay. And generally in micropapillary less than 3 mm you can observe. Okay. And what about nodal staging we discussed, no? Now, can you tell me when do you do completion thyroidectomy, Sana? What is completion thyroidectomy?
After doing hemithyroidectomy, if the specimen surgical histopathology warranties a post treatment radioactive iodine, like more than 4 centimeter extra thyroid extension nodes are positive in and aggressive variants on histopathology. In all of them, we consider to do completion of thyroidectomy.
So what will be the approaches for completion thyroidectomy?
In initial, first we'll have to go through the notes, whether, if for example, right hemi was done, whether the left was virgin plane or not.
Generally, it will be virgin plane, or if you have done surgery,
you should not be.
Yeah. So you should not touch. Okay, so you can go through lateral approach, you can lateral or backdoor approach, and you can go from the opposite side. Okay.
Okay.
So by lateral or backdoor means division of omohyoid ke sath. Okay.
Okay.
So then okay. So what is the role of frozen section in a thyroidectomy? When will you do, and what is the accuracy of frozen section?
The main indications are inadvertently removed parathyroid you want to confirm, and you'll have to reinstate, and second, suspicious node for your surgical extent. In these two, it is warranted. In if you want to confirm your pathological diagnosis post lobectomy, you can do, but the false negative rates are more than 15%, so they're not very accurate.
Yes, 25% around 15 to 25%. Okay, so accuracy will be 75% only. Yeah. So other than that, lymph nodes and parathyroids are one thing that you can get through frozen. Okay. So if you want to address or not, okay, you will send that lymph node as you told. If central compartment are positive or lateral compartment are positive, you have to address either of them. Okay. Yes. Then what are the levels of lymph nodes which are more commonly positive in thyroid malignancies?
3 and 4 followed by 2. So most commonly we address 2, 3, 4.
Hey, what is more common in thyroid?
The central. Sentinels are central.
Yeah, 6.
Living 6 and 7. Living that the lateral ones are 3, 4 followed by 2 and 5.
Yeah. Okay. So when will you do prophylactic central compartment neck dissection?
In
One you told medullary.
Thyroid. Okay, you're telling in all of it.
All indications for prophylactic central compartment, you tell me.
Okay, in differentiated thyroid, it is T3, T4 extrathyroidal extension, medullary thyroid cancers.
If
Then
lateral lymph nodes are positive,
lateral neck positive.
or if they are advanced CAS which are suspicious of either inspection, palpation, or radiological. Okay.
Yes.
So then what? Okay, fine. Now you tell me the steps of thyroidectomy.
Okay, a patient is placed on OT table with caucus position. Then you will pain drape with adequate exposure from submentis till just below the suprasternal notch, like the upper thorax is little exposed. Then you'll go with the transverse neck crease incision, raise the subplatysmal flaps. Then you will incise the cervical fascia, retract the strap muscles. Then go ligate the middle thyroid vein if present. Then you'll go to the superior pedicle ligation. Individually ligate, preserve the external branch of superior laryngeal nerve. Carefully delineate the parathyroids in relationship to the RLN, search for it, preserve, and inferior thyroid is ligated. And from lateral, then you will mobilize the isthmus. The same procedure is repeated on the right side. Then achieve hemostasis, place drain, and you will close the straps and subplatysma, then the skin. Subcutaneous.
Okay. So where is ESBLN located? Do you know any triangles with respect to RLN and ESBLN
Joel's
identification?
Beer's triangle is RLN. But Joel's, I think, is external branch of superior laryngeal. Only these two I know.
So anyone else?
External is Joel's or space of Revis, and then RLN, Lorage, Simon, Riddle.
Yeah, Behr's is for Behr's or Riddle's triangle is for
RLN.
So can anyone tell me boundaries?
Beer's is lateral.
ITA makes the base, common carotid lateral, medially esophagus or RLN itself.
ITA is superior. Common carotid is middle, I think.
Yeah.
Sorry, common carotid is the base.
Lateral.
And ITA is superior, and recurrent laryngeal nerve as one of its third side. So generally, this triangle is posterior to tracheoesophageal group. What about lower triangle?
Lower esophagus is medial and RLN is content.
Yeah. And what about the lateral border is carotid? Okay. Superior is inferior pole of thyroid. Okay. So what about Joel's triangle? What is it for?
External branches, superior laryngeal.
Yeah. What are the boundaries?
The lateral is retracted superior pole, medial is cricothyroid, and superior is the sternohyoid muscle insertion.
So in Joel's, medial and lateral borders will be from the thyroid vessels, and superior border will be strap muscles. Okay. So ESPL1 will be in the floor of the triangle. What is Simon's triangle?
Simon is like Riddle's only, but the medial is esophagus, RLN is content.
Yeah. ITA, esophagus, and common carotid. Okay. And what is RLN triangle? It's below. Clue. So thoracic inlet, okay, strap muscles and inferior thyroid, okay, inferior part of thyroid. What is triangle of concern, Sahana?
Where is Beres ligament, triangle of the Beres ligament. No?
What is there in triangle of concern? Why is it concerned?
Recurrent laryngeal nerve, ma'am. ITA and recurrent laryngeal nerve.
ITA and recurrent laryngeal nerve. So it will start bleeding, no? Then you'll be confused. Okay. So it will have trachea medially, recurrent laryngeal nerve laterally, with thyrothymic ligament at the base and Beres ligament at the apex. Okay. So once ITA starts bleeding there, no content, then you will not be able to see anything. What is space of reefs?
Upper pole, like Joel's only.
Yeah, upper pole of thyroid gland.
Medial to the superior thyroid vessels.
Medially cricothyroid, laterally retracted upper pole, and superiorly
Yes.
sternothyroid.
Yes, that is space of reefs. So what are the points at which you will find, once we look for recurrent laryngeal nerve?
The thyroid tubercle, inferior thyroid artery, is the relation of
those triangles, and then Zuckerkundal, tubercle, and inferior corner of thyroid cartilage, and tree.
Tracheoesophageal groove.
Yeah.
Okay.
And all triangles we mentioned now, triangles, those Lores,
Yeah. Yeah. Most commonly you will see at the tubercle of supracandal and tracheoesophageal groove. And in relation to what is in relation to thyroid vessels, okay, where is the superior and inferior parathyroid located?
the inferior, anterior, posterior, or superior.
In relation to nerve, sorry.
RL.
Superior is most consistent.
Superior is where?
Posterior.
Most lateral, posterolateral, and inferior is anteromedial.
Anteromedial.
Yes, correct. And ESBLN, it will be less than or more than 1 centimeter from that superior port. What is the classification for the ESBLN variants?
Cerney's classification.
Cernia classification.
Type 1, type 2 AB.
Yes, type 1, type 2 AB. What is it?
More than 1 centimeter in relation to the superior pole is type A. Within 1 centimeter, but not in proximity with the pole is 2A, which is common. 2B is it is within the thyroid tissue.
Yeah.
Above and below.
Below the pole, 1 centimeter.
Above.
Below.
Within the 1 centimeter above, within 1 centimeter below.
A is above, B is below.
Yeah. So suppose, that's about the thyroid. No, now you tell me what are the complications of thyroid?
The immediate complications of immediate and delayed, or delayed or permanent. Immediate are hematoma, hypoparathyroidism, temporary hypoparathyroidism, temporary RLN palsy. There can be airway compromise. Then delayed ones are permanent hypoparathyroidism and permanent RLN.
So regarding parathyroid, okay, how many when hypocalcemia sets in, okay, how much of it is temporary, percentage of temporary hypocalcemia?
About 14 to 20% are temporary, less than 4% are permanent.
About 50%, 30 to 50% are temporary. Okay.
Okay.
Permanent will be only 12%, 10 to 12%. That too, if you do total thyroidectomy with the central compartment neck dissection, then it will be around 12%. If you don't do central compartment neck dissection, it's only 1 to 2%. Okay. So discussing each. So if bleeding occurs during thyroid surgery, so what is the most common site of bleeding that might, and what are causes of bleeding? Immediate versus reactionary hemorrhage.
Okay, slippage, technical slippage of sutures is primary. So while either in the thyroid bed or above that.
So most common site of bleeding is from which? It is at the superior pole or inferior pole?
Superior.
So, yeah, pedicle. When you are ligating that superior thyroid pedicle, it slips off. Okay. When it that is due to slippage of ligature, it can occur in reactionary also. Okay. And suppose medial thyroid vein is there and you have not identified, that also can be source of bleeding.
Okay.
Then what? Intraop injury to the parathyroid. So suppose how do you check that it is parathyroid tissue?
You will see for the color, location, size. Then they'll be rounded, encapsulated with tan brown or salmon color. When after ligation of pedicles, they become dusky. So capsulotomy, usually the venous congestion can be relieved. Then it can be transplanted to the ipsilateral sternocleidomastoid after mincing it in 1 millimeter cube diced sizes.
Where do you implant in case you want to implant?
If it is non-familial, then you can use sternocleidomastoid. But for familial, they say brachioradialis.
Okay. Fine. So, what happens due to hypoparathyroidism? This is hypocalcemia. So, do you have how do you treat hypocalcemia? Temporary versus permanent. First, temporary we'll discuss. What is the level of calcium at which what you want to do? Cutoffs.
If it is decreased more than 1.5 to 2 millimole, less than the level, or 1.5 milligram per deciliter. Like if it goes below, we'll see further whether the patient is symptomatic, asymptomatic. Then we'll see for the levels of the calcium. And PTH is also done.
Yeah, but is there any true hypocalcemia versus how do you calculate that?
Calculate
Adjusted calcium with albumin levels.
Yes. Anyone knows how to calculate?
1.2 into the deficit 4.5 minus the value of the albumin plus your serum calcium.
Calcium level. Correct. So, what is this one? Which calcium you look for?
Total.
Ionized.
In serum, it is total. Then you will do for the calculated. That is.
Yeah, ionized calcium is more specific. Okay. So, yeah, fine. Then, what about how do you manage calcium hypocalcemia?
So we'll check for Chostek's and Trosio's sign. If the patient has paresthesia by clinical symptoms and signs, then we'll check for the calcium levels in the parathyroid. IV calcium gluconate is given a 10 mg over 10 minutes, and the doses can be repeated at frequency of 2 to 3 hours till the symptoms subside. If the patient is asymptomatic and the levels of calcium are more than 8.5 in the normal range, or even asymptomatic 7 to 8.5, oral supplementation with calcium is sufficient.
Okay, there are some guidelines. Okay, what you told is practical way. Okay, ATA guidelines has cutoff from 7 to 8. Oral you should give. How much is the bioavailability with different calcium tablets? Okay, all this I'll send you that guidelines. Okay, and after class.
Okay.
Then yeah, so below, for roughly to remember, below 7
yeah,
you will give IV, and above 7 you will give oral. Okay. So then you will also supplement vitamin D. Okay. Yeah. So what about what else? What are the other complications?
Recurrent laryngeal nerve palsy. So patient may have voice change. RLN and external branch of superior laryngeal nerve injuries.
Yes.
And apart from that, flap edema.
Yeah, wound infections.
Wound infections.
Yeah. So these are grossly the thyroid complications. So when do you want to give? You told radioactive iodine ablation in a differentiated thyroid cancers.
Yes.
Okay, what are contraindications for giving a radioactive iodine ablation? What radioactive? What is the thing you want to give radioactive iodine?
Isotope 131, that is most commonly available and used for both diets.
What about 128?
128, 123, the availability and the T half is less, so procuring them and usage is not widely used.
Okay, what is T half? Like
131 is 8 days. 123 is 13 hours.
8 hours. Okay, Adama. Okay. So what about like using this iodine 131? If you are using for diagnostic purpose, as you told, I'll do in a radioisotope scan and all. So how much you want to give? And if you are doing it for a therapeutic, this one, how much you want?
Okay. For the diagnostic scan, the upper limit is 3. So less than 3 millicurie should be given. So 1 to 3 is for diagnostic scan. For your
when will you do it, Tanya? When will you do a scan?
Radioactive iodine indications are to consider in the intermediate risk category, and for all high risk, we would consider to give it as adjuvant therapy. So
yeah, what is the interval post surgery that you want to see it in a scan?
4 weeks, 3 to 4 weeks.
Why?
Yes, sir.
You have to achieve
he told already.
Yeah, TSH.
So you have to make them hypothyroid. So TSH should be minimum of 30.
30 for uptake.
Okay. Yeah, when you send them to nuclear, this one, they will first see what is the TSH level. Okay.
Yes.
So as you told, diagnostic will be 1 to 3 microcurie. So what will be the duration when like scan, when will you stop if patient is on this one, T3, T4 supplementation? So
Okay.
when will you stop them?
T4 is 4 to 6 weeks. T3 is 2 weeks. Then
so if patient is not able to, if patient has become grossly hypothyroid, okay, patient doesn't have some time. So what do you want to do?
Recombinant TSH.
What's the dose?
It is 0.9
and how much? Yeah, 0.9
mg per kg given for consecutive one and first and second day. After 24 hours, you will do as a radioiodine.
Okay. So what is stunning effect?
The diagnostic dose of radioiodine will lock the receptors from uptake of a therapeutic dose RAI. So
that's when you. That's the reason they fear of the CT and all those things are there. Okay. So, what is stimulated thyroglobulin and unstimulated thyroglobulin?
With TSH suppression, then you check it is stimulated. If you do it irrespective, then it is unstimulated.
So that hunger for iodine, this one occurs in stimulated. Okay. So TSH, look, generally 0.9 recombinant TSH is given. How much is the cost? Do you have any idea?
60 to 90,000 per dose.
It will cost you around 90 lakhs. Okay. Almost 1 crore. 90 lakhs. lakhs.
90.
Okay.
90.
Yeah, 90 lakhs. Yeah, 90 lakhs. So it's very costly. Okay. Yeah. So what about what are the most common? Okay, which study has told that in low risk you can avoid radioactive iodine?
Estimable 1 and 2. One did the study for seeing the low RAI dosage, and they found that by giving irrespective dose, low or high, it did not make a difference in low risk category.
Estimable 2 has told that in low risk you can avoid.
Yeah.
So yeah, what are the contraindications for giving radioactive iodine?
One is age more than 70, it is not indicated. Then
Pregnancy and lactation.
yeah, pregnancy.
Pregnancy, lactation. And anything else?
Children.
Can you give it in children?
Children.
Can you give it in children?
No, ma'am.
Okay. So so what before ablation? What tests you want to do? Baseline test.
We'll get the TSH, TG, and anti-TG antibodies.
Okay.
TSH more than 30 milli international unit per ml, their uptake will be more. Then you will see for the baseline TG and anti-TG to correlate whether it is a true or a false positive anti-thyroid antibody. I mean TGs.
So if you leave the what are the most common sites where you might leave a thyroid tissue while operating?
Tracheoesophageal groove near the RLN and
Superior pole, pyramidal lobe, and tracheoesophageal groove.
Yes.
tuberculosis.
And thyrothymic
Yes. These are the most common sites where you leave the thyroid tissue. Okay. So what is remnant thyroid radioactive ablation, RRA?
when the dose of the indication is in N0 non-metastatic patients in intermediate risk category and selected low risk, there is a role for remnant ablation with 30 millicurie.
Yes. So that is the minimum amount of radioactive iodine that is required to ablate that residual tissue. Okay.
Madam, remnant
So what?
is like this, ma'am. When we give diagnostic,
Sorry?
when we give diagnostic, that's iodine.
Diagnostic is 1 to 3 microcurie.
Yeah. And then after we see how much uptake is there.
Yes.
If there is any remnant thyroid,
see whether it is only in the bed, whether it is in the nodes, whether it is in the bones, whether it is in the lungs.
That is called remnant ablation.
Yeah, in
remnant thyroid radioactive. So minimum dose that you will give is 30.
30, yeah.
Okay. Yeah. So what is 30 is to a bed? 30 to 50. Then what about nodes?
50 to 100.
What about lung?
Up till 150, 100 to 150. For bones, up till 200.
What is the maximum radioactive iodine you can give? One shot. Cumulative.
1000
Sorry,
millicurie or 1 curie.
How much?
1000 millicurie or 1000.
Cumulative in like I think it is 450 to 600. Just check once. Okay. Yeah. So what is what do you want to maintain? What will you see in follow-up of papillary thyroid cancers or differentiated thyroid cancers? Follow-up?
Follow-up, we will get a ultrasound for structural disease. Biochemical recurrence, we will assess by TG and anti-TG. And we will have a goal of TSH depending on the risk category.
So what is it for low risk?
0.5 to 2 is for low risk. Intermediate, it is 0.1 to 0.5. Less than 0.1 is high risk. Then you will see whether for your TGs, unstimulated, stimulated, and it should usually be undetectable or less than 1 nanogram per ml. After more than 10 suggests biochemical recurrence. If there is ultrasound pickup of nodes or any new recurrences, that is structural recurrence. Anything in between, ma?
Structural, biochemical,
excellent response, and intermediate.
Yes. What are definitions for that?
Excellent responses. There is no structural disease on ultrasound. Your TG unstimulated up to 2 is acceptable. Less than 1 is stimulated. And in biochemical recurrence, it is TG more than 10 nanogram per ml. With no evidence of structural disease on the ultrasound. In structural recurrence, it is ultrasound, there is evidence of disease. In intermediate, it is between 2 to 10 nanogram per ml is your TG with not conclusive ultrasound findings. It can be less than 8 mm of nodes central or less than 1 centimeter lateral.
Okay. Suppose in low risk, Sahana, so how frequently would you like to follow up a low risk or differentiated thyroid cancers?
After your whole body iodine scan and low risk we would not have done. So it is 6 to 1 yearly. You will get your ultrasound and biochemical tests.
Yes,
generally it is yearly. Okay. So for high risk and all 6 monthly. Okay. What all you'll do? Clinical examination, ultrasound neck, TFT, thyroglobulin as well as antithyroglobulin antibody.
Yeah, calcium. What about calcium and calcium?
Calcium is optional. Okay. Just not on follow-up, regular follow-up criteria, calcium is not there. Okay. Generally, if it is calcitonin is done when it is medullary. Okay. So, yeah. So, 6 to 12 months, ideally 1 year in low risk and 6 months in high risk. So, what else I want to ask? Yeah. Suppose you have on follow-up, okay, for differentiated thyroid cancers, down the lane after 1 year, you have seen some uptake in the neck. And then some neck nodes are present. How do you proceed with?
Okay, neck nodes are there and there is no evidence of disease, like, and you'll get your TGs, your biochemical parameters you will see. Then you will do an FNA. If it is inconclusive, there is a role for TG washout. Then if it is still, if the TG is normal, then there is only nodes you will see for the size and TG washout. If both are negative, then you will again repeat it 6 monthly ultrasound with TG. Then you will see the trend, whether it is increasing, whether TG is raising.
Suppose after 3 months, it is in decreasing trend.
Increasing trend. TG.
Decreasing trend.
TG is decreasing and node size is not.
Yeah, it is static.
It's stable. Then we will follow it up.
So, and if it is increasing trend?
Then it is suspected recurrence. Radioactive iodine scan is indicated.
Okay. What is tennis?
It is in raising TG with negative scintigraphy, where there is increased TG, but there is no pickup. So this could be refractory dedifferentiation, or that is when there is role of PET-CT, ultrasound and PET-CT for structural disease.
Okay. So you'll do a PET-CT, okay, in tennis. So what about suppose if it has become radioiodine refractory? So then what you want to do?
Now, if it is surgically operable or if it's a limited disease, surgically operable or inoperable, we'll have to see. So if it is operable, like only bed recurrence or nodal recurrence, you can operate. You can go and operate. There is role for empirical high dose RAI. The other things, retinoids are also used. Then role for TKIs are also there if it is metastatic inoperable. EBRT and role for.
Can you increase the radioactive iodine concentration or refractoriness? You can decrease. Is there any drug which
Retinoid? I'm not sure.
Have you heard of cellumetinib? Yeah, that is used. Okay, so it can increase the uptake. Okay, to certain extent. If it is little radioactive iodine refractory, then this can increase it radioactive sensitiveness. Okay. So why? What is the thyroid suppression replacement dose? Thyroxine.
Okay. In treatment of malignancy, we use a suppressive dose to decrease the risk of recurrence. So 2.5 to 3 microgram per kg is used to maintain TSH at the cutoff value.
Is it same to adults and children or anything?
Adults. This is adults. Children.
Yeah. What is it for children?
Not sure, but it's little higher. I think.
Yeah, it's 4. Okay, fine. Then?
So you will give suppressive dose and maintain TSH at the goal, which is prefixed. Then you will serially assess them yearly if they have met the TSH goals. And this is done according to ATF till 5 years. Since it's a dynamic risk stratification, you can
adjust the dose. Yeah, based on risk criteria. So why are we bothered about this thyroid, giving thyroid hormone or suppressing it more? What does it?
Like thyrotropic, these tissues are they are TSH driven. So in order to decrease the recurrence.
So whenever you decrease it more, no, there are more incidents. What is the complication of that? They lead to myocarditis, yeah, arrhythmias and osteoporosis. Okay, so that's why this all this dynamic risk stratification has come into role only to prevent that complications. Okay. So, by the way, this morular is follicular variant, okay, not the papillary.
Okay.
Cribriform and morular are this one. Okay. So, any role of metastatectomy in thyroid, differentiated thyroid cancers?
Yes, for R0 status. So as much as possible, the operable structural disease has to be removed so that the dose required for radioactive.
Yeah, if they are radioactive iodine away, then you can treat them with radioactive iodine ablation. Any drug you know which is used in metastatic DTC?
TKI, sorafenib and lenvatinib.
Lenvatinib, correct. Okay. Any drugs which you know which are used in medullary thyroid cancers? Metastatic?
Caprositinib.
And?
Vandatinib,
What are the trials?
For DTC, it is decision and select trial.
As far as I know, Zeta trial and
exam trial.
Exam trial. Okay.
Which is the other one?
Exam and Zeta.
Zeta. Okay. Lenvatinib and DTC is decision.
Yeah. So what else? You do any IHC in thyroid?
For metastatic, yeah.
No. Generally, any IHC positivity in thyroid, what all you'll get?
Thyroglobulin, calcitonin, these two.
IHC?
TTF. TTF.
TTF? You can get TTF, you can get galectin 3 and HMB 45. Okay. Okay. In this tall cell, why is it called tall cell, Sana?
Cytomorphology. They're 3 times taller than the width.
Yes. And columnar mein? 2 times the base. Okay. And classical will be cuboidal. Okay. And were there any trials which studied about central compartment dissection, overall survival and morbidity? Any trials you are aware of?
That's a meta-analysis.
They're all Chinese meta-analysis. This Zhang, Chang, and all those things. Okay. Yeah. So that's differentiated thyroid cancers, and just 5-10 minutes about medullary and anaplastic, and then we'll close. Okay.
5-10 minutes. Anaplastic,
so
medullary.
in as you told, the differentiated and anaplastic, okay, are differentiated by TTF negativity versus CK7 positivity. Okay.
Okay.
Right? Yeah. So I'll only tell you the differentiated and anaplastic varieties are spindle cell.
Okay.
Then giant cell. Okay. Rhabdoid variety, squamoid variety. What else? So there's one more is there. Angiomatoid variety and paucicellular. Okay. These are the varieties of anaplastic. Okay.
Okay.
Yeah. What are the IHC in lymphomas?
CLA, CD45, TD, that is leukemia, TD, CD3 and 10.
CD20 and 45 generally. Okay. And any targeted therapies you can use in differentiated thyroid cancers? Any drugs, you know? We have discussed the genes, no?
BRAF, Vemurafenib.
Yes.
Or BRAF.
Vemurafenib can cause any cancer?
Ma'am?
Out of box question. Can Vemurafenib cause any cancer?
Skin malignancy.
Yeah, squamous cell carcinoma. Yes. So, yeah. Other than that, dabrafenib, Vemurafenib, these are this. And anything, NTRK fusion inhibitors can be used. Alkin, yeah. Okay. ALK inhibitors like crizotinib and all can be used. Okay. So, anaplastic classification. 4A, 4B, 4C. 4A is confined to thyroid. 4B is lymph node positivity, and 4C is metastatic. Okay. What is median survival in papillary CA, follicular CA? Which has got the best survival?
Papillary followed by follicular and worst for anaplastic.
Anaplastic, how much is the median survival? Median survival.
3 months.
6 months.
Yeah.
6 months. Okay. If they survive more than 6 months, then it is more. Okay. They can be treated if they survive for if the survival is around 1 year. Okay. So what are the modalities of treatment for anaplastic CA available?
Surgery is
EBRT.
If you can do a surgery R0, you can go ahead and do total thyroidectomy. If it is for only palliative decompression, then it is isthmectomy. Then you can give other non-surgical modalities like EBRT.
Can you give chemotherapy?
CTRT.
Chemo is not.
Can you give chemotherapy?
In 2B, madam, if it's unresectable and we wait for markers to come, we can give chemo till we get the mutation target.
So what is the chemo that is given in anaplastic? Fatty carboid, same like ovary. Okay? Or single agent doxorubicin can also be tried. Okay. Yeah. So all this, if they have this breathing difficulties, tracheostomy, stomachectomy, all that can be done. Okay. So yeah, and you treat them. You address lymph nodes. Same like if you want to operate, it is same as PTC guidelines. Okay.
Okay.
Medullary thyroid features. One is like we saw the amyloid features. Other than that, what will be the spratinus? They'll be hypercellular. Okay, and they'll have this discohesiveness. Discohesiveness because they're not differentiated, no? And salt, pepper, chromatin will be there.
Okay.
Medullary are one of the which have salt, pepper, chromatin. What's the origin of medullary CF from?
Neural crest.
Blastoma, neuroblastoma.
So, what are ultimobrachial bodies?
They're the
Neural crest.
neural crest. Rests of neural crest tissue from which organ?
C cells. Okay. So, any like any other neuroendocrine tumors, okay, they'll have the salt, pepper, chromatin, and plasmacytoid appearance. Okay. So, other than calcitonin, can you do any marker which is more specific in medullary CF? CEA.
Chromogram.
Fine. CEA and calcitonin. Generally. Okay. Yeah. So, generally for medullary CS, what kind of cross-sectional imaging you want to do?
PET CT is the investigation of choice.
So you can do DOTA PET. They have more neuroendocrine features, no? Or if PET is available, you can do that. Okay, but availability and cost are issues. Okay, and in what all you will see biochemically in medullary CA an evaluation. One we told parathormone. Okay, one we told calcium, vitamin D.
Vitamin D. Yeah, markers for calcitonin, CEA, phosphorus.
Phosphate and alphos. Okay. Yeah. Systemic scan can be done if there's suspicion of that MEN syndromes. What is MEN1?
MEN1 is involvement of anterior pituitary, parathyroid, thyroid with pancreatic.
All three P's. Okay. MEN2?
MEN2 has parathyroid, medullary.
MEN2A, I mean to
strong. MEN2B is with medullary, marfanoid featers, then mucosal ganglion.
Where is cutaneous lichen amyloid is present?
MEN1, it is of two types. One has cutaneous and the other one has, I think, Hirschsprung disease.
A ganglionosis. So, what is triad of pheochromocytoma?
Episodic hypertension,
sweating. Palpitation. So, what is the diagnostic of pheochromocytoma?
Plasma metanephrin.
24 hours urine metanephrin. But we do plasma because it is easily available. But gold standard is urinary metanephrin. It's cumbersome, no, to collect 24 hours urine and all.
1, 2, 3,
okay.
4.
So, suppose they are associated with MEN1, what do you want to address? Suppose they are associated with pheochromocytoma. What do you want to address first? Necro or
pheochromocytoma? What do you want? Pheochromocytoma is priority. Once that is stabilized and managed, then we'll go for thyroid malignancy. Ma'am, you're not audible. Can't hear you.
And I was getting a call, so I cut it. So, what is the incidence of occult lateral lymph node spread in medullary thyroid cancers? Around 60 to 70%. That's why central compartment neck dissection you should always do and see for if there is any lateral. Okay. So if central compartment is positive or not, and see if there are any lateral, you have to address that. Okay. So we already talked about calcitonin. Then about 200, what you want to do? Which neck dissection?
Ipsilateral.
Contralateral.
Bilateral neck disease about 200, ma'am.
Go Sidan.
Above 200 it is
Sidan
superior
मतलब वही
mediastinal
calcium
lymph
ना.
node dissection. 50 to 200 it is
Over
bilateral.
go.
Okay. 20 to 50 it is central compartment.
500
Less
नहीं
than
क्या
5.
mediastinal का.
Above 500 metastatic chances of metastasis. Yeah. So how frequently will you do calcitonin, Sana, in medullary thyroid cancers?
Surveillance.
Every 3 monthly you have to do. Okay.
Oh.
And suppose it is any role of radiation.
Yeah, inoperable recurrence only, otherwise.
Palliative, ma'am.
If there is margin positivity or extranodal extension, you can give DBRT. Okay. And if it is more than 1000 calcitonin, that is suggestive of disseminated disease. Okay. Yeah. You can try targeted treatments that we have discussed, banditinib, cabozantinib, and what did I tell? That is selpercatinib. Okay. So they're not available in India. Okay. Pralazotinib and selpercatinib. They can be used as targeted treatment, but not available in India. Okay. Suppose calcitonin is decreasing, CEA is increasing. What is your impression?
Desire आ रही है.
So it is becoming more of de-differentiation. CEA is marked for de-differentiation. Okay. More loss of differentiation. It is becoming epithelial in origin. Okay.
Okay.
So yeah. Other than this, you can do chromogranin, synaptophyte. Somebody told chromogranin, no? That. So serotonin and all that. So what about anywhere else calcitonin is raised other than thyroid? So bronchial, prostate, okay, wherever neuroendocrine tumors can occur. Okay. So more than 100 picograms per ml calcitonin has almost 100% positive predictive value for medullary syndrome. Okay. Any provocative test for calcitonin?
Calcium pentagat.
Yeah. So more than 2 times the normal value, it is suggestive of medullary thyroid cancers. Okay. And if it is recurrent medullary thyroid cancer, what is the line of treatment? Any neuroendocrine tumor, what you will do?
Again, you will see whether it is DOTA uptake or it is differentiated. Whether it is local, regional, or distant. Then depending on that, we will.
So you can give this lutetium dotatate therapy like any other neuroendocrine. Yeah. So MIBG can be given if it is disseminated disease. Okay. But always remember surgery is the best. Okay. Familial emphysema last 2 minutes. Okay. Familial emphysema, kitne members are minimum to be diagnosing as
10 members. 10 members.
Previously it was 10 ma, now it is 4. Okay, at least 4 members should be there. Okay. So then what else? What are this?
4 member in like first generation or second? Is there any specific or total number?
Call back है ना?
Over 3 generations.
All the 3. Okay, at least 4 members should have that mutation. Okay, again in fact they are there, no, exon 10, 11. What are high risk? Yeah, mild risk. Dangerous is what? 91. Yeah. So where if it is done in less than 1 year, yeah. So other intermediate will be 6, 0, 9, 11 and all those things. And 10, 11, 15, 16 will be ret mutated. Okay. Then that's it. I think we have covered more than thyroid.